Good afternoon. Welcome to day 2 of Cardiac College Online. For those of you who we didn't meet yesterday, my name is Paul O, and I'm the medical director in the Cardiovascular Disease Prevention and Rehab program at the University Health Network. We work at 2 sites, Toronto Rehab and the Peter Munk Cardiac Center. It's our pleasure to be bringing you this series of webinars that are devoted to keeping you informed and staying healthy through these challenging times. Today, we will be looking at the topic of coronavirus and the heart. And this is part of our Tuesday series that is devoted to hot topics. That is, topics that are drawn from news headlines that are affecting our own heart health. We would very much appreciate commentary from our audience about what you think might be relevant and important to inform topics going forward. The specific areas for today were actually drawn from conversations that we have had with some of our participants in our rehab program. And we hope that you'll all enjoy this. As we put this together, we thought, wow, this is such an informative area for us to get into. I'm very pleased that I'll be joined by my colleague, Dr. Fernando Rivera Thorel, who is a cardiologist originally from Mexico, and he will be, he is doing a fellowship with us in our cardiac rehab program, and he will provide his expertise in the area of high blood pressure and coronavirus and medications. By the end of the session, we hope that you will have greater information about, firstly, the possible relationship between certain heart medications and coronavirus infection. Is there actually something there, or is this all hype? And, you know, an overarching theme that I think is very relevant to all of us today, given the large amount of information that is bombarding us on a regular basis, whether it's through television, radio, social media, about COVID-19 and our health. Is this, in fact, real news? Is it fact or is it fiction? And how might we be able to tell the difference? Once again, we would like to highlight the ground rules for this session, that these webinars are for education only. If you have a specific question about your own heart health, we'd encourage you to connect with your own healthcare provider for specific advice about your situation. We do encourage you to submit questions through the Q&A part of the platform. We will endeavor to answer as many questions as we can, but we'll do so in a general way as opposed to a personal specific way for you. We may not be able to address all the questions of interest that come up today, but we'll do our best to answer them in a timely fashion. And we were able to, for instance, look at your questions last evening, write responses, and get it posted up this morning. And we'll try to continue with that cycle as we move forward. As we did yesterday, it's nice to start with a little bit of polling about who are we? And I can see that there are about 55 people online, and we would love to just ask, where are people from and what are your backgrounds? So we get some idea of the audience makeup. Yesterday, to let you know, we had audience representation from Canada, the United States, Latin America, and Asia. And today, it seems like we have a very similar representation. Shout out to our friend from Asia who is signing on at some unusual time early in the morning. So thank you for that. And let me share with you these results that we're showing that most people are indeed from Canada, some from the United States, Latin America, and Asia. Many of you are rehab participants from our local programs in Toronto, as well as from programs outside of Toronto, and we're glad that you're able to join us. And we're also delighted that we have colleagues on the line who also work in healthcare. Thank you for continuing to provide healthcare services in these difficult times. Okay. So moving on to the heart of the matter today. So the topic will be based upon, again, conversations that we've had with some of our patients. Here's an example. And for those of you who might only be joining on the phone, let me describe this. Here's a headline from Newsweek magazine that describes controversial study links COVID-19 severity to ACEs and ARBs, despite warning of no sound scientific basis or evidence. So this is one example of several headlines that were in the media that decried maybe some of the common drugs that we are taking are actually very dangerous. And we thought that this would be a great example of a topic for us to unpack further. And it was informed by a couple studies like this. So it looks like legitimate medical literature. And I'm showing you here on the screen 2 examples of papers that were around this topic. Number one, by an individual that seems like a very well-qualified author in the Journal of Travel Medicine, curiously, who writes, hypothesis: angiotensin converting enzyme inhibitors and angiotensin receptor blockers may increase the risk of severe COVID-19. That sounds like a very scary headline, because these are common drugs, and if they're going to increase your risk of bad things, that sounds very dreadful. The second major paper was published in a very prominent journal called The Lancet, and one of its subjournals is devoted to respiratory medicine. And they asked this question: are patients with hypertension and diabetes mellitus at increased risk for COVID-19 infection? You'll see both of these were very recent, within the last couple of weeks. We're right up on these hot topics with you. And we thought this is a good place for us to start to dive in. One hand, media is picking up these headlines because they kind of love these hot headlines that say there's real danger going on and we need to inform you right away. And we have esteemed medical colleagues that are publishing these interesting kinds of articles. We would like to point out, though, that the articles deal with, for Dr. Diaz's, he states the first word here is hypothesis, meaning that this is an idea. It's not a proven concept, it's an idea. And the second paper in the Lancet asks a question. It does not tell you what's going on, it's asking a question. But the media says something else. They will say definitively, there is risk, there is harm, you must change. Okay, let's unpack this further. I want to take one little step back and talk about what is this topic area that is of importance and interest. So we've been talking about angiotensin converting enzyme inhibitors, angiotensin receptor blockers. Let's ask the question, what the heck is angiotensin in the first place? People who are in our program may have had a conversation with our team members or even me, and you will recall that we like to go through this explanation in the following way. Angiotensin is a substance that floats around in our bloodstream. It's actually produced inside of our bodies. And if you think of what that word might mean, it's relevant to how our blood vessel system behaves. And if you look at the word angiotensin, you can break it into 2 components. The first being angio, and some of our patient partners, as well as our professional partners, will recognize that we take angiograms or have angioplasties. These are procedures on the blood vessels throughout the body or around the heart. Angio is then referring to something related to blood vessels. And tense, I think everyone knows what tense means. Tense means tense. And if you look at the 2 fists that are shown on this slide, then we're saying that there is this substance in our body that might make blood vessels tense. So I'll do that, and I'll even shake and quiver as I do that. That's very exciting. We are wired that way because then that's how we can control blood pressure. If we have a lot of angiotensin, blood pressure goes up. On the other hand, if we have less angiotensin effect, we'll calm down. And there's this cycle through the day and through our lives where there's more or less angiotensin. For the blood vessels, our blood vessels will squeeze and relax in response to substances like angiotensin. Hence, if we can think of ways of modifying angiotensin, then we might use certain medications to reduce blood pressure, relax the strain on the heart, and allow it to function more ably. And indeed, there have been many studies done over the last 30 years that have talked about the benefits of angiotensin medications that affect angiotensin to reduce blood pressure, to reduce the risk of heart attack, to reduce the risk of stroke, to protect kidneys if we're living with diabetes. So there's this well-entrenched therapeutic pathway affecting angiotensin. And hence there are these medications. So in the headline from Newsweek, we talked about ACEs and ARBs. Some of you are familiar with that lingo, others, this might be something new. ACEs refers to something called angiotensin converting enzyme inhibitor. If we think of angiotensin, that stuff that makes blood vessels squeeze, converting enzyme is the pathway where we make angiotensin. An inhibitor means you block it down. So these drugs that we might also know as the prills, because that's how they end their names, like captopril or enalapril, ramipril, you've got the whole cadence. These prill drugs that you might be taking for your blood pressure or your heart health or protection of diabetes are commonly used medication, and they block the formation of angiotensin, hence have those positive effects. The cousins to these angiotensin converting enzyme inhibitors are these things called angiotensin receptor blockers. So if our body makes angiotensin, another way of reducing its effect is to work a little bit further downstream and blocking where angiotensin might bind to a receptor on a blood vessel, for instance. We know this family because they all end in sartan. Some examples, losartan, candesartan, irbesartan, etc. You've got that cadence. These medications block the action of angiotensin. The net effect of either one of these, and they're used somewhat interchangeably to lower blood pressure, reduce the strain on the heart, keep your overall vascular system healthy. And again, long history over decades that these medicines are good at preventing bad things like heart attack and stroke and death. So good reasons to use these medications. Okay, so what's the deal now with these medications in the era of COVID? I'm going to hand the presentation over to my colleague, Dr. Rivera, and you will see that I will exit the seat, maintain my physical distance from Dr. Rivera as he comes in. So hang in there for a second.
Hi, I'm going to explain how this relationship between this medication and the COVID-19. So we know that the COVID-19 has 2 points of entry into the body. One is in the cells in our intestines, and in the other side, we have in the lungs, we have these cells with the receptors, with the ACE2 receptors, where the virus will link to the cell and is going to be the point of entry to the body. So we know that these medications that we are mentioning is going to bind to this receptor as well. So the question is, what is going to happen to these receptors if we already are taking these medications? So there is the theory that could point that if we are taking the medication, the receptor levels they are going to go up, and that could be related to a more severe infection or to more risk of getting infected. We don't know that yet. That is the hypothesis that is being mentioned in the media and in the different studies. So one of the questions that we have is, are the people with hypertension is more likely to get COVID-19? So we have reports from China and Italy that says that 15 to 30% of the patients hospitalized with COVID-19 had high blood pressure. But if we think about that, like 15 to 30% of the adults living with high blood pressure, so we don't know if that is a causation or it's just that we have a lot of people with high blood pressure. So that statistics is related to that. The other question will be, does the use of ACE inhibitors or ARBs make it more likely to get COVID-19? And we are going to go back to that point. So we know that 15 to 30% of the patients hospitalized with COVID-19 have high blood pressure. But roughly 15 to 30% of these patients have been taking the therapy. So we're finding a small proportion of these patients. And we know that 30% of the adults living, they have high blood pressure and they are being treated with this medication. So, and this vast majority of patients are not infected and they're not required to be in the hospital. So there is also evidence outside saying that these medications could be also beneficial. So the hypothesis is that the medication is going to interact with the lung and is going to reduce the severity of these infections. But at this moment, we don't have the evidence to make this conclusion. In the other part, so we are seeing a lot of news talking about if this is going to be deleterious to our patients or even could be beneficial. So Dr. Varkis, the director of the Comprehensive Hypertension Center of the University of Chicago, published this a couple days ago that I find very interesting. So he states that this is a huge controversial issue, but there is no clinical data to support that hypothesis. And this is just a hypothesis based on limited animal data and a lot of speculation. And we don't need sensationalism journalism on this matter. We need stability. We need proper information to create conclusions to our patients. So what does the international experts are saying about this topic? So there was a lot of publications from the Canadian Cardiovascular Society, the European Society of Hypertension, and the Hypertension Canada, and even the American College of Cardiology and the American Heart Association. So that their recommendation is do not stop taking your blood pressure medication unless advised by your physician. That is not related to COVID-19, could be related to another medical reason to stop your medication. So that is our recommendation. If you have any question, you can always go back to your cardiologist or your general physician to ask if you have to make any of these changes. But what we know is if somebody stopped taking the medication, that could lead to uncontrolled hypertension and more hospitalization rates. Another thing that we want to comment about this topic is that there is a lot of rapid publications outside on this moment. So that means that there is a lot of information going on, like medical and scientific information, but we are not having the right time to see if this information is accurate or is just creating or has bias maybe. So we have to be very careful to of how we are going to interpret this information that is being published. So I will leave Dr. Paul O to continue with this wonderful presentation.
Great. Thank you, Dr. Rivera. And let me just pause for a second to see if there are any Q&As. And we have one question from one of our colleagues. What about other types of medications? There's another family called beta blockers. Do we have any thoughts on those in relation to COVID-19? So thank you for that question. Usually in the course of our medication sessions, we do talk about other families of drugs. Beta blockers, you'll recognize these ones because they end in LOL. I have a few friends in the audience in this room and they're smirking at me because they know I like to say that story. So the LOL drugs like metoprolol, bisoprolol, propranolol, and these are completely unrelated to these ACE inhibitors, angiotensin receptor blockers. They work through a completely different pathway. At this point, there isn't thought to be even any inkling of a relationship to that ACE receptor, ACE2 receptor, and COVID infection. Once again, these medications are very helpful for controlling blood pressure. For people living with heart failure, they improve the performance of the heart. So I think the same advice would apply as Dr. Rivera has suggested. Do not stop these medications. They have a good purpose. If you have a specific question about it, please do check in with your healthcare provider. Thanks very much for that question. And let me move on to part 2 of this story. And it actually all comes together, which is very cool. You might think that we're crazy conspiracy theorists in this room as well, but we're trying not to be. We're trying to be counter to that. Another headline that you may have heard about, I'm just going to poll my audience here, which consists of 6. Has anybody heard if there is any concern about medicines like ibuprofen? You might know them as a brand name like Advil, and the COVID infection or heart disease. And I'm getting 4 people nod out of me. That's 66% of us think that this is important. My next question might be, do you know where this started? Where this controversy started? And I think this is such a fascinating story, because the obvious answer might have been, well, there should have been a major medical publication that talked about this. Instead, there's something else. There's a little bit of medical stuff, but there's actually more other kinds of things. And this is a very important topic for us to unearth right now. And the answer is shown pictorially. And what I'm showing on this slide that some of my colleagues can't see is I'm showing you a picture of a flag of France. So why is there such concern about taking ibuprofen? A flag of France plus my next image is Twitter. Flag of France and Twitter. This is much more fun to do with a live audience, because then I can look at the puzzled expressions on your faces. But the way the story goes is that France's health minister, Olivier Véran, expressed in a tweet on March the 14th, very current, that he suggested that anti-inflammatory drugs such as ibuprofen and cortisone, he threw that one in as well, which is completely unrelated, structurally, molecularly, could be an aggravating factor in people with COVID. On the same day, the entire French government, they put out a report that said NSAIDs, the whole family of anti-inflammatory drugs that includes ibuprofen, were linked with grave adverse effects in patients affected by COVID-19. Well, that sounds like there must have been a medical report of really serious bad things that were happening with ibuprofen. Are you ready to dig a little bit further? Follow along, this is fascinating. Because France said it, the minister said it, then the government said it, well, the World Health Organization said, we better say something too. So they issued a statement on that same day that recommended that people suffering from COVID-19 symptoms should avoid taking ibuprofen, and they cited the French officials that were warning that the anti-inflammatory drugs could worsen the effects. This sounds very exciting. Ministry of Health in France, the government of France, the World Health Organization. What's the deal? If I go back to the beginning, we introduced the topic of blood pressure drugs, a couple of blood pressure drugs, and a couple of these articles that expressed a hypothesis. And buried into this article that was from the Lancet Respiratory Medicine that asked the question, are patients with high blood pressure and diabetes at increased risk for COVID-19 infection? There was a statement near the end of the article that said, ACE2, you know that receptor that's in the body on the lungs that the virus might attach to? The author made a statement that ACE2 can also be increased by thiazolidinediones. Wow, that's a fancy diabetes drug that very few people use. And he also mentioned ibuprofen. There was no support for that statement, but he made that statement. And apparently somebody picked that up and said, well, I'm going to make an announcement about this, about the grave adverse effects of ibuprofen. There was no report of bad things happening to people, but somebody made a report or somebody made a statement. In this current political, economic, social climate, I think we sometimes are seeing these interesting statements coming out based upon the lack of evidence, perhaps. And what we see further is social media amplification. What was seen on Twitter feeds was tweets like this one, quote, a lab from Vienna, quote, and quote, a hospital nurse in Vancouver, close quote, reported that there were very bad things happening with ibuprofen in their environments. When someone did some fact checking, the lab in Vienna that was in question denied ever putting anything out there. They were unable to find this nurse in the Vancouver hospital. The hospital actually denied that there was anything from here. And then when people started doing further digging, they realized actually this was not real messaging. It was actually bad stuff that people were putting out. Go figure. What's the rationale for this? But it does say how almost a throwaway comment in a medical paper could be picked up politically, stated up, could be retweeted a million times, that would change a major health authority like the World Health Organization to change and make a major statement. It's very interesting that what happened subsequently, the same day, later that same day, is the World Health Organization then needed to make a new statement. And following the question, could hashtag ibuprofen worsen disease for people with hashtag COVID-19, the WHO then said later that day, based on the currently available information, the World Health Organization does not recommend against the use of ibuprofen. They actually did a double negative on that. So they kind of backtrack. And what they said was actually, they didn't say this, but I think you can get the sense. What they said is we probably said something too soon before there was any information. Very kind of interesting. So of course, this creates a huge cascade because many of us are taking anti-inflammatory medications. And certainly if we have a virus infection like COVID-19 or influenza or the cold, we might be reaching for these kinds of drugs because we feel rotten. We have a headache, we have sinus pain, we might have a fever. And there are lots of these NSAID drugs. So I found a very useful commentary from the BC Pharmacists Organization. So I guess the point here would have been, let's find some credible sources of information. I would have said WHO would have been one of them, but sometimes we're wrong. We'll look for some triangulation. So there's these conflicting reports, and the early reports indicated NSAID drugs could worsen the effects of the virus. In fact, I can't even find an early report that said NSAID drugs can worsen the virus, but go figure. There are many examples of the NSAID drugs, like ibuprofen. There are many others that weren't named in the report that would have been equally implicated if this was true. Drugs like naproxen or diclofenac or celecoxib or melacoxam, there's dozens of these. Why is it relevant? Because we are taking these kinds of medications if we have a fever. So 2 points here. If you have a fever and you've got respiratory symptoms, please do get checked out. We're not trying to minimize that. That's really important. If you are having a fever and you're treating pain, these medications may be helpful. They don't treat the illness itself, per se. So just being clear about that. If you're sick, get yourself looked at. If you're taking these medications, they can help with symptoms. They don't affect the infection, per se. These are not antiviral medications. What should you do? And maybe the only kind of good positive thread through this was, sure, if you are concerned about some medications, always think, might there be a better or safer option? And we have this conversation with every one of our rehab cohorts, that if you're looking for something to treat your headache or back pain or knee pain, then we might start with something simple like acetaminophen. It is not one of these non-steroidal anti-inflammatory drugs. Chemically, it is very different. It works very well for pain and can help with a fever if you've got it, not for COVID, for something else. And it doesn't cause stomach upset or bleeding. It doesn't affect blood pressure. So this is a good overall choice. And that was the only good part about the French thing, the WHO thing, is they said, maybe you should avoid those drugs, use acetaminophen. I agree with that. The rest of the hysteria, I don't so much agree with. Non-steroidal anti-inflammatory drugs, just to lay it to rest for our client population, non-steroidal drugs, non-steroidal anti-inflammatory drugs, they're helpful. They can be really good for things like acute inflammation. If I tweak my knee, I tweak my back, if I have a headache, then I take a couple of doses of an anti-inflammatory, I'll feel better. That's great. That's not going to cause any difficulty. And you can still do that if you've discussed that with your physician, nurse, pharmacist, and you've agreed that's a reasonable pathway. These drugs, by the way, are also good for fever, and that's why they are sometimes the common drugs that we might reach for at home, or if your kids have a fever or something like that. The disadvantages of NSAIDs, though, that's why we might have some concern. Unrelated to COVID, that we know that these kinds of anti-inflammatory drugs, as well as aspirin, have the potential to cause some stomach irritation. And occasionally it may cause an ulcer. That is a little hole or a burn in the stomach that may lead to some bleeding from the stomach or the early part of the intestine called the duodenum. For some people, they can be serious. For some very few people, it can lead to a worse outcome. In addition, if we're taking a lot of these NSAIDs for a long period of time, it can be hard on the kidneys. And if you've already got some impairment of kidney function, then these would not be the best choices for us. If you're living with heart failure, what's not shown on the slide, but what we mean by heart disease, if you're living with heart failure and you have a tendency to hold on to salt and water, well, these medications can trick the kidney to hold on to salt and water. So it can make heart failure worse. And there have also been some reports in the past, unrelated to COVID, that some people that use these NSAID drugs over a long period of time may show an increased signal of having another heart attack. Therefore, we have always had the conversation for years that these medicines should be used very carefully. If you need something for short-term pain, acetaminophen is a better option. There are some people that say, well, the only way I can manage my arthritis of my knee is to take these medications. Then have that conversation with your doc, limit the dose, limit the exposure, and say, if this is the way that's going to work for you and you can monitor blood pressure, that might be okay, but do discuss that with your physician. What about aspirin? The little baby aspirin that many of us are taking after having had a heart attack or an angioplasty or a stroke or a surgery. This is something different. We know that there are clear benefits of using these medications to prevent stroke, to prevent heart attack. This was not mentioned in the controversy, but it's interesting how it kind of got lumped into the social media frenzy. These little doses of medications don't hurt the kidneys. They don't hurt heart function. In fact, they can be protective for you. Do not stop these medications if you're on them. If you're concerned, have a chat with your healthcare practitioner about them. Interesting. So for those of you who want to read more about this kind of story, I like websites like this one called FactCheck.org. And they go back through that story of the French ministry, this little mention of a medical paper, the amplification through social media, and then trying to present some reasonable guidance through all of this. It's challenging navigating this landmine field or this swamp of information. And we're hoping then that a session like this might actually have a place to provide some reasonable information and create some balance to the headlines that we might be hearing. So I'd encourage you to take that look. I'll just finish off this section. I'll check the Q&A and then wrap this up. So is it dangerous to take an NSAID now? Well, it is no more dangerous or less dangerous than it was before. If you're living with a heart condition, we just want you to be cautious with these NSAIDs. And if there was something else that you could take, like acetaminophen, that's the way that it would go. The reports that NSAIDs worsen lung problems from viral pneumonia, including COVID-19, I think the conclusion is exactly the same as Dr. Rivera presented on the blood pressure medications, ACEs and ARBs with respect to COVID. We really don't have enough information about this. If you are stabilized on these medications, please carry on instead of really shaking up the boat at this point. Okay. And this, I thought, was a lovely kind of headline from UConn today that said, especially in this time of COVID-19, that we might want to reach out to credible experts in the field before we start to change things around. Okay, let me put this, just check the Q&A. One of our colleagues is asking, will these presentations be posted online? And I can answer, yes. I can answer yes. In fact, yesterday's presentation is posted online, and we will endeavor within a 48-hour period of time or so to be able to post these along with the answers to any questions that might be coming up if there are some things that we haven't looked at already. Another question is, who should we trust? Each country has its casualties. This is absolutely true. If I interpret the second part of the question, yes, there are bad things happening all over the world. Absolutely. And it perhaps gives the perspective on why some regions, why some ministries might be more conservative than others, might be quicker to launch a warning than others, and we do have to be aware of that. Who should we trust? I think we need to check some things out. And unfortunately, it might not be social media the place that we trust. If someone is quoting medical literature, what Dr. Rivera and I will do is actually go look for that medical literature to see what is the veracity, the truth, what is the content of that. And my rule of thumb, here's a thumb, for medical literature, like what means evidence to me is if somebody has studied several hundred or several thousand people that got exposed to one thing that are compared to several hundred or several thousand people that look the same that got exposed to something else, if there's a clear difference between the two, then I'm thinking there's something here. Anything short of that, there's an idea that is in search of proof. That's what I would say. Another question is, why do they say that baby aspirin is not good for women to take? And the answer on this one, and Heart and Stroke actually just published with experts a new guidance around aspirin. And I think the theme here is that every medication has some good parts to it and also some bad parts to it. The benefits of aspirin that we talked about are prevention of heart attack and prevention of stroke and prevention of death. That's the good side. The bad side, I'm waving with my hands just to be excited here. On the bad side, as we've already said, that aspirin, even a baby aspirin, a little tiny baby aspirin, has some risk of causing damage to the stomach and bleeding in some individuals. That risk is very small. So we need to look at how much gain there will be versus how much risk there will be. If someone is living with heart condition or has had a stroke, the risk of something next happening is actually somewhat high. The aspirin has a benefit there, and the benefit of the aspirin is much higher than the risk of stomach bleeding. On the other hand, if we look at young women as a particular group who are otherwise healthy, the risk of having a heart attack or a stroke is exceedingly low. They would have the risk of bleeding from the stomach, though. If I gave a bunch of young, healthy women aspirin, what I'm really going to see are risks of the stomach and very little benefit related to heart attack and stroke. And this has been generalized in a number of big studies to say that aspirin may not be good for women. I would qualify for that to say that aspirin is not good for women who otherwise don't have risks for the heart or risks for the brain. If a woman has had a heart attack, a stroke, an angioplasty, a heart surgery, then aspirin is definitely as good as it is for men. My English is falling off the page right now, but aspirin can be good in those situations. So we always have to think about the individual and whether aspirin or any other medication is the right thing. And the last question that I'll address, is there any concern that blood pressure medications will not be available? And perhaps that question is grounded in the notion that there have been some, quote, shortages of blood pressure medication over the last months and couple of years because of the availability of different ingredients, that really it's part of that whole international chain of ingredients coming to a certain factory for production. At this point, there is very good attention to maintaining the supply chain for essential products like blood pressure drugs. I don't have any immediate foreseeable concerns that any one thing might not be available, but I'm also confident that you and your healthcare providers, your doctor and pharmacist, if there was any shortage of any one particular medication, that you would be able to find something else that would be a reasonable substitute, either within the immediate family of the class of drugs or the extended family or even broader than that. So I don't think that that's something that we need to add to our growing levels of concern. Terrific. And finally, I'll take this question on before we end. A follow-up question to an earlier one. Each region has its own genetic base, lifestyle, or level of education. And absolutely, these are important considerations in our propensity around health. Absolutely, that our health outcomes might be very different depending on where we live and what's around us in terms of food and activity and environment. We know that socioeconomic status will also affect what goes on with our health. And it might be our access to health care or the way that viruses might spread, for instance. The common thing out of all of this is that there are some things that we can't control, like some of these factors that we talked about, but there are many things that we can control. And going back to our messages from yesterday, and you're hearing them from everywhere, like what is the recipe to be healthy with our heart conditions today? And I would say, pay attention to the basics. Wash your hands. Don't touch your face. Stay away from people that are ill. And in any social gathering, if you happen to be in one in the grocery store or anywhere else, maintain your physical distance. And that's going to go a long way. Whether you're living with a heart condition, you're living with high blood pressure or diabetes, or if you are healthy in the population, please follow all of these things for yourselves and for each other. Okay, that's going to end off our Q&A part of this. I really appreciate your attention and your participation. I'll remind you that a lot of our resources are available online. And if you go to that Cardiac College website, you're all very familiar with this now. If you want more information about medications in particular, go to the Take Control tab. And on the left-hand side, you'll see tools for managing your condition, as well as reading the booklet called Taking Your Heart Medications. To our 68 friends online, we thank you for joining us today. And thank you for your questions. Is there anything else that you want to bring up? There's a couple more questions, and I will endeavor to answer those in written form, and we'll post those online. Thank you so much for your time and attention today. To my colleague Crystal, we'll end the session here today. We'll look forward to seeing you tomorrow at 1 o'clock. The topic will be nutrition to boost your immune system. Undoubtedly, that's going to be an outstanding and informative topic. So thank you very much for joining us today.